and we need to formulate dynamic response and recovery plans. So, to discuss these vital issues, we are privileged and honored to have with us some very eminent and outstanding speakers today who are luminaries from the public as well as the private healthcare setup in India. So without much ado, I would request our Honorable Vice Chancellor, sir, Lieutenant General Bipin Puri. Over to you, sir.
Thank you, Amita. Friends, distinguished guests, senior faculty, fellow Georgians, ladies and gentlemen, I consider it a singular honor to kickstart the proceedings of this webinar, which I'm sure will be a great learning experience for all. Friends, the year gone by has been a year of uncertainties. While it is true that this pandemic has caused a great deal of human suffering, it is also true that our collective response to this pandemic has been one of the most formidable stories of humankind, human adaptability, and human resilience. The statistics actually tell the magnitude of the problem. Till date, as they say, nearly 59.5 million people have been infected with the virus, and 14 lakh people have died globally. Huge numbers. India has about 92 lakhs confirmed cases, and about 1.3 lakhs people have died. We may be tired, friends, of COVID-19, but I don't think the virus is tired of us, as the onslaught continues unabated. Although much has been discovered regarding the transmission and presentation of the disease, very little is still known about the pathophysiology of COVID-19. A interesting latest BNJ article points out the binding of the virus to ACE2 receptor. Now, these receptors, as we all are aware, are present in the nasal epithelium, pulmonary alveolar epithelium, oral mucosa, liver, kidney, GI tract, and the vascular endothelial cells. In roughly 80% of the patients, the virus continues to be localized in the nasal epithelium and causes just a mild URTI. But in 20% of cases, there's involvement of the lower respiratory tract, leading to potentially lethal pneumonia and ARDS. Now, since the virus is also vasculotropic, and also by virtue of its binding with the ACE2 receptors, it may cause thrombosis at various vascular beds in addition. Now, evidence-based medicine, friends, shows that SARS-CoV-2 virus management is both limited and is constantly evolving. As we say that human intellect has always evolved by rejecting outdated information in favor of new truths. And this is exactly what is happening. One thing comes in today and it's outdated and it moves on, and something else is happening the next day. And with virus guidelines transforming each day as new information and data is being processed, one is of the firm conviction that one size fits all has become a thing of the past. Lately, the WHO Solidarity Trial, the interim results published on the 15th of October, have actually been a shocker. 12,000 patients recruited from 500 participating hospitals worldwide. And they found that 4 treatments that we've been using, remdesivir, hydroxychloroquine, interferon, lopinavir, ritonavir, have no mortality benefit in patients hospitalized for COVID-19. Now, these have cast doubts on the protocolized therapy being practiced by many healthcare institutions around the world. Also, the preliminary results from the recovery trial conducted in the UK showed that dexamethasone, 6 milligrams per kilogram per day, given for 10 days, prevents mortality in severe and critically ill patients. And this one protocol, however, has stayed on as a standard of care. Friends, ladies and gentlemen, leading from the front, King George Medical University has been involved in the collective effort to blunt the aggressiveness of this pandemic in UP at large, but in the state capital at Lucknow in particular. The faculty and the administration of the King George Medical University have taken up this gigantic challenge head on and have evolved innovative protocolized therapies for the diverse spectrum of the novel coronavirus presentations. Apart from establishing the largest patient care COVID hospital in Lucknow in the state of Uttar Pradesh, the university, in collaboration with various national and international bodies, has been a leader in enhancing scientific knowledge and has contributed to making policies for diagnostics, therapeutics, research, use of AI for the diagnosis of classical and atypical COVID infections. I once again thank all our guest speakers, our additional Chief Secretary, uh, Government of Uttar Pradesh, Dr. Rajneesh Dubeji, Professor Daresh Trihan, Professor Balram Bhargav, Dr. Das from the ICMR, Lieutenant General P.P. Verma, this morning for adding to the glitter and sparkle to our academic deliberations. As we continue to make the world a safer place, these discussions, I'm sure, will have a huge implication in the time to come. And with this, I hand over the to Dr. Amita Pandey to take the proceedings further.
Thank you, sir. We would now start the webinar with a message from our Additional Chief Secretary, Medical Education of Uttar Pradesh, Dr. Rajneesh Dubeji.
Good morning. It's a pleasure to be associated with this webinar on COVID-19 management organized by King George's Medical University, Lucknow. COVID-19 has brought its own challenges, and it was like a bolt from the blue in the month of March when this assault came. And in hindsight, what we can say with satisfaction is that the UP government, with the able support of organizations like KGMU, Sanjay Gandhi PGI, Institute of Medical Sciences, BHU, and a host of medical colleges, both private and public, we have been able to tackle this huge challenge and its uncertainties. We have been able to undertake several innovations, and today, with a sense of confidence, we are facing the so-called second surge. What COVID has also brought with it is the inner resilience of people. And a half months continuously. Every day I recall those meetings used to be a challenge because something new would erupt, and then we will recalibrate our strategy. How to expand ICUs at a fast pace, how to innovate in terms of our COVID protocols, how to train the people out there in the field. They were very vital ingredients. And everybody contributed, the corporates contributed through funds, and in the end, we were able to tackle it. The second point which I would like to highlight was this constant innovation. SGPGI brought out the first of its kind protocol for COVID management when even the government of India was preparing its own at this national level. When it came to non-COVID infections, non-COVID patients getting infected in emergencies, we had our own protocol of segregation and red OTs, which we rolled out. Antigen test mix coupled with the standard RT-PCR test, we developed our own mix, we developed our own strategy, and ultimately it proved to be successful. Electronic COVID care support system, virtual ICUs, and a host of such clinical protocols and technologies have also helped us in reducing the case fatality rate and keeping it within acceptable limits. And WHO has also appreciated the efforts of Government of UP. The Reserve Bank of India, the Government of India have all expressed satisfaction at the way the biggest state in India, UP, has been able to manage this protocol, despite its huge population and despite its constraints of healthcare infrastructure. So I think there are lessons to be learned, and this webinar, which is being attended by a galaxy of different experts from corporate medical side, from people who are into policy making, from people who are working in medical institutions abroad, all Georgians, of course, but people in their own right who are stalwarts, will be able to chalk out some strategies, some focus areas where we could focus our energies and tackle COVID-19 on a long-term basis. Thank you. Jai Hind.
Can't hear you.
Of health research.
Please speak again. Yeah.
With this, we move on to the academic bonanza of today. And our first speaker is Professor Balram Bhargav, Director General, Indian Council of Medical Research and Secretary, Department of Health Research, Ministry of Health and Family Welfare, Government of India. Professor Bhargav actually needs no introduction to this audience. We all know him as an outstanding cardiologist, a leader in biomedical innovation, public health, and medical research. He's the recipient of innumerable national and international awards, including the Padam Shri, and today he would be speaking on the COVID-19 crisis, lessons the world can learn from India. So over to you, sir.
Thank you so much, the Honorable Vice Chancellor, distinguished speakers and friends. This is a great Georgian get-together. Last 15 years or so that it has contributed to healthcare in the nation, starting from the First World War onwards. And this is the Third World War that we are now dealing with, and how this institution has contributed. I will now make 17 minutes presentation, basically talking about the role, what is the status of the vaccine, what are the drugs, and where we stand, mainly on the role of I will not be touching upon PPEs and oxygen and hospital beds and all those issues, and just talk about what ICMR has helped the government and how we have been able to scale up. And really, we had underestimated our capacity as not only as scientists, as members of the ICMR institutions, as Indians. I think we are able to deliver much, much more than we estimate ourselves. And that has been the greatest learning experience. So I will start with the slide. I hope we can get a window. Yeah, I hope you can see my slides.
Yes, sir, we can see it.
Okay, so I'll go ahead. So this is the role of ICMR. Now, the first question which we ask is, why has the pandemic occurred and why should it occur? But if you see in this millennium from 2000 onwards in this 21st century, we have witnessed a large number of exotic viral infections which are more frequent and are more complex, whether it be SARS, MERS, Zika, Nipah twice, H1N1. So it's been a burst of these infections, and we feel that we'll have much more of these infections in the near future. Why? Because there has been a change in the environment, change in the ecology, rapid urbanization, neglected public health spending. And that is the most important thing that has been brought to the front to everyone, not only in the Indian government's perspective, but internationally, that public health spending has not increased with time. And that is where we have not delivered as far as these pandemics are concerned. And this was presented and discussed at several meetings of the group of ministers, several meetings of the COVID task force that was in the parliament, and also the 15th Finance Commission. And they are now all in agreement and in sync to increase the budget for public health as well as research spending in the country. And as the Prime Minister has promised that the GDP has to increase from 1% to 2.5% by 2025, where it may happen earlier, and we should see much more money into the healthcare spending. This is the new and emerging infections across the world. The green ones are the newly identified regions. The red ones are new viruses and the emerging infections and diseases. This is from the WHO. And if you look at everything happening across the globe, we have SARS, we have avian flu, we have the swine flu, we have human retroviruses, and we have the WHO blueprint, which has got the 10 viruses which are on the bioterrorism list as well, and we need to be worried about them in a big way. Now, how has India's response been? Someone mentioned at the beginning that Dr. Pandey mentioned that our response has been quite good in India. In fact, I would say that India, being the largest democracy, has given its respects to its people's voices, and it has recalibrated its intervention measures very systematically. Most of important, it has been serious right from the January this year when we came to know about this virus. It has been a whole of the government approach, which has been calibrated, proactive, preemptive, and a graded response, depending on what was available in the country, how it has to be rapid scaled up, and the guidelines were accordingly tailored and measured in a measured manner so that we did not face any crisis across the country. It was science driven with best practices and evidence based. More importantly, we have a very strong leadership which has had excellent communication, and every 15 days to 2 to 3 weeks, we have had a meeting of the Prime Minister with all the chief ministers of states, and that has kept the nation along. The last thing is that we have resisted the flirting with the herd immunity as a nation, which we have seen in many of the Western nations, whether it be Italy or United Kingdom or Sweden or even parts of USA, where they tried to play around with herd immunity and faced the dramatic consequences. Yes, we were late. The pandemic was slightly late in India, so we got some good learnings from what happened in the West, and therefore didn't mess around with herd immunity. We have stuck to the 5T strategy, which is of test, track, trace, treat, and use of technology, and we've used that in the whole nation, and that has helped us tremendously. I don't want to talk about the numbers. We've already talked about that. I'll be talking a little bit about testing, then the other pharmacological agents that we use, and last about the vaccine. Now, testing, we have upscaled it rapidly. The vision was to have a laboratory in every district. We passed a gazette notification that every medical college in the country, whether it be government or private, should have a lab, a pure RT-PCR lab for viral detection, and 273 out of 281 government medical colleges have responded. We have 185 of the private medical colleges who have also responded, and we have been able to set up labs in various difficult terrains in the Northeast, in Ladakh, in Kargil, in Andamans, in Lakshadweep, and this has happened with the help of 14 mentor institutions, and King George's Medical University being one of the major mentor institutions for the northern region. The diagnostics for molecular tests, initially the existing molecular test was a standard PCR. Then we had the Cobas machine, which had a high throughput with less requirement of manpower, but the machines are very limited. They had in March earmarked 16 machines for Asia. That is what USA told us. We have 16 machines for Asia. We got them rapidly, one at a month, but they are expensive as we speak today, and they do have some downtime in these machines being very automated. What we did was we used the TrueNat and CBNat platforms, which we are being used for tuberculosis, and I'll highlight this in the next few slides, how we have done that. The other molecular tests which are in pipeline are the CRISPR and the Feluda test, the Tata MD check, which they have been, which was in the press in April, May, and it's still not been able to come into the field. Now Tata has started the manufacturing, and hopefully it should be in the field in December. We should be able to use it in Delhi and Ahmedabad as the first starting point. Then we have the RT lamp, which has slightly less sensitivity, but we have been institutes from DBT as well as ICMR have developed RT lamp, and that may be deployed in the program. A dry swab collection method is also being validated, and we are looking at that collection in the saliva, although being in the US. We have found that the sensitivity is looking on that, and hopefully that may be in the pipeline. In terms of what we did in terms of the calibrated part was that we, in the large cities and urban areas, we set up the RT-PCR labs as the gold standard. In the district levels, we deployed the TrueNat and the CBNat machines. And in the field, we deployed the rapid antigen test, and India was the first country in the world to deploy rapid antigen tests in the month of June, whilst the WHO has given emergency use licensing for rapid antigen tests in the month of September, and now the United States has started using it, while nearly half, 30 to 40% of the 13 crores tests that have been done in India have been done by these rapid antigen tests being manufactured in India, and now 50 companies are manufacturing them. 14 have been validated by us, and about 6 of them are available on the government e-market. Now, I wanted to emphasize on the TrueNat, because TrueNat is a machine with indigenous platform developed by a Goa-based company, and we worked on it for tuberculosis diagnosis and got it validated, WHO pre-qualification in 2018, and therefore we had a large number of TrueNat machines in the districts and smaller places, and we were able to deploy very rapidly for testing of COVID-19. We had used it, we validated it for Nipah testing, first time in the world. We also validated and made it possible for testing for leptospirosis, again, first time in the world. And we, this is a laboratory in a suitcase, which is portable, battery operated, works in remote areas, and the results are available in 45 minutes. And this was appreciated in the Lancet, where we now have 2,530 TrueLab workstations across 500 in 530 districts of India. This was appeared in Lancet because the United Kingdom had developed a molecular test only in the month of September, and that featured on BBC and also on the in the Lancet Infectious Diseases, where they talked about a new molecular test in September, and then we wrote about our test being available, and they published that and really appreciated that. We started this in April. So we were ahead of the curve in many things, and that is where we realized that we have been underestimating ourselves as a nation, as scientists, and that should change. High throughput laboratories, we were able to set up high throughput laboratories in different parts of the country, north, south, east, and west. And in Noida, at the NICPR, we have got an assembly line of 12 RT-PCR machines with 3 automatic RNA extractors, and we can do up to 12,000 tests in that facility. We have recently launched the mobile RT-PCR lab with a joint initiative of Spice Health and ICMR, and this has been inaugurated just last week, and it is being deployed in Delhi. One lab, they have got NABL accreditation, and we have now been able to deploy, hopefully in another week, 10 labs in India, in Delhi, in remote areas of Delhi, where in north and northeast Delhi, where the epidemic is raging. In terms of self-reliance, we found that initially in March and April, we had to import these kits. These kits were available from China, and they were charging any amount of money because they said, I have a supply, I have to supply to USA, I have to supply to Europe, I have to supply. And that is when our scientists in all our science ministries and some startups got together and started developing these kits. And more than 1,020 kits have been validated at 24 ICMR institutions, and they have been approved as viral transport mediums, or the RNA extraction kits, or the rapid antibody, or the rapid antigen kits. And once they have been approved, we have found that they have met with the international market. They are now being exported to many countries in the world, and they are also led to the reduction in cost tremendously. At the beginning of the epidemic in March, the RT-PCR kit was costing 1,150 rupees, and it has come crashing down to now 138 rupees on the GEM. We had the viral transport medium and the RNA extraction kit available for 320 rupees each, and they have come crashing down to 91 and 94 rupees per test. So initially in March, the test were 1150 plus 320 plus 320, which is just the kit, about nearly about 2,000 rupees plus lab expenditure, electricity, and other things, and that is why it was expensive. But now it is less than, it's under 500 rupees for that guest. We had the non-ICMR, the NABL has worked overnight, I mean 24/7, and they have been accrediting labs with inspections, virtual inspections, and now we have 30 labs in the ICMR system which are for quality control across the country. This is a most important slide which I wanted to highlight because during the lockdown in March and April, we had limited number of labs, say about 150 odd labs for the whole country. Today we have 2,200, and at that point in time, we had to make supplies of kits, reagents, pipettes, as well as set up new labs. And at that point in time, there was a mission called Mission Lifeline Run, and the ICMR was not sleeping. We were working 24/7 at that point in time. And not that we're not working today, but at that point in time, it was 24/7. And we had partnership with the Indian Air Force, the Indian Revenue Service, Indian Postal Service, Niti Aayog, and the railways. And this 24/7 mission carried consumables, testing commodities, medical supplies to various parts of the country. And this was a huge mission where at 2 a.m. in the morning, samples were sent. They were collecting, and there were sorties going on by the Indian Air Force, helicopters, etc., and taking these commodities in a big way. And the story is mentioned on our website as how testing was scaled up in March, April, and in May during the lockdown when it was difficult even to move out. Here I want to emphasize again that where India has done well is that we followed the middle path. We didn't have a draconian lockdown that we had in China in December, January, where we have visuals of large amount of injustice being done there. And we didn't have the lockdown that we had in the UK or the USA where everyone was roaming around. We had something in between, and that really flattened the curve. We distributed the curve. We were able to set up our healthcare facilities, our testing facilities, our oxygen, our beds, etc., and were able to reduce the mortality tremendously as a nation, and that needs to be highlighted. In terms of number of tests, we are second only to the United States. We have done about 13 crore tests today, and how we have scaled up from 150 labs in March, April to now about 2,200 labs. Now, as the labs were scaled up, we also had, we calibrated our testing protocol initially with travelers in February, then in March, contacts, RE patients, healthcare workers, and travelers. And then we talked about ILI and pool testing, and then hospitalized patients, immunocompromised patients, pre-surgery in June, once we started having the antigen test. And in September, we really liberalized it in such a way that it became testing on demand, and we had it available across the country. In terms of the demand forecasting and supplies, we had 20 institutes of ICMR set up depots in different parts of country, which ensured that the supplies were taken to every laboratory, and the laboratory at the King George's Medical University played a tremendous role in helping us in validation as well as in stocking, and served as an ICMR depot for testing commodities. And this was launched in April 2020. It was a web platform for really measuring the requirements and dispatch quantities exactly, and that was working again. In terms of the data entry, we had a data entry portal of ICMR, which has the testing details of more than 13 crore samples today, and when we completed 100 million, we have posed several questions, and many of these publications are in press and are in preparation on 100 million test study, and we call it the HMT study, where we took the data from the 100 million tests and looked at it and looked at reinfection and other issues in terms of clinical trends, policy making, resource planning, and decision making. In terms of capacity assessment, and again, how do we make the purchases, etc., we had nuanced models for projections. We had the tendering platforms. The government e-portal and the government e-market portal worked tremendously well. And more interestingly, yesterday we completed our third-party what you call audit by the Ministry of Health, the World Bank, as well as one more agency, and we have come clear in that as well. So that is really a major stress for me personally, how that has worked well. We developed we isolated the virus in the month of March, and we were the 5th country in the world to isolate it. Subsequently, we developed the ELISA assay, which was used for the serosurvey as a national program. In terms of research oversight and dissemination, we had a national task force formed, which was responsible for taking decisions on calibration of testing strategy, advise the government on lockdown and containment strategies, develop advisories for discharge, provide oversight for ongoing clinical research, development required for clinical trials, drugs, and vaccines, explore new repurposed treatments, and develop clinical management protocols. And this is a living document which is prepared regularly. We have been able to publish 3 issues of the Indian Journal of Medical Research. We have also issued advisories and letters to states, stakeholders, and it has been, as I would say, as a whole of a nation approach to this problem. And we have been now the 4th issue is online and ahead of print. In terms of therapeutics, we have worked on equine antisera, monoclonals, plasma therapy, remdesivir, and screening of various antivirals. We have been able to develop the immunoglobulin like the Regeneron one at the institute in Delhi, and this has been tested in animals, and now further testing is going on. We are in a partnership with biological events. The equine antisera and the human monoclonals as well, and we've had publications on their success. In terms of convalescent plasma, this is another very interesting story of the ICMR, because this was a major study that was embarked upon during the lockdown on the 20th of April, and we completed the study on the 15th of July on a war footing with 39 public-private hospitals, and we included 464 patients, and clearly demonstrated that plasma is not working. This is the first largest randomized trial in the world on convalescent plasma. Having said that, in terms of the randomized trials that have been done across the world, we can name only a few on our fingertips. One is the recovery trial, which showed that steroids are working. 2 is the solidarity trial, which is showing that remdesivir is not working. And then we had the trial from the United States, which said that the lopinavir and ritonavir is not working. And then we had the trial from India, the convalescent plasma trial, which was published in BMJ and had 2 editorials, one of them clearly talking about how research has been democratized in India, where we have really utilized this opportunity to train our district hospitals, our regional medical colleges, rather than this research work and private hospitals and private medical colleges, rather than this research being done at the apex institutions as it has been in the past. So this really leads to a new paradigm in terms of how research is going to be done in India in the future, with India becoming a hub of clinical trials, and the DHR ICMR taking a lead on that. And we have now recently been approached by the NIH to utilize these hospitals again for the monoclonal studies. We've been approached by industry from Germany with the monoclonals and other pharmaceutical agents to scale this up as for the trials, for the randomized trials. So this has been a major experience as far as establishing India's scientific prowess in the world. This is the WHO Solidarity Trial, which is the third trial, which I said really made any difference in the world. And it clearly showed that remdesivir is not working, and 10% of the patients were from India and was led by ICMR Institute of Nari, and they were able to do it at various centers rapidly again. In terms of epidemiology and surveillance studies, we have isolated the virus, and we have taken 10 swabs every fortnight from 100 viral research laboratories and tested for the genetic evaluation and done their NGS, and have found that different clades have less than 1% divergence in genetic structures. There is none of the mutations so far culminated in change in pathogenicity, transmissibility, or virulence, and the virus really has not of less than 1%, and therefore the treatment parameters, or whether it be the vaccine or the drugs that are going to be effective or are effective, will not face major problems in using this. In terms of the National Sero Survey, we embarked again. This was another major first Sero Survey was done at the beginning during the lockdown, and we employed most of the people from our tuberculosis survey and were able to collect blood samples from 700 villages and 70 districts across the country, and were able to demonstrate that the seroprevalence was 0.7%. But recently we have done the second sero survey on August 17 to September 2, and showed that the seroprevalence is 7%, it being about 4% in rural India, 8% in urban India, double of that, and double of that, 16% in urban slums. So we are still very, very, very far away from herd immunity, and the third sero survey has just begun and should have the results in December. Sewage surveillance was done using our poliovirus sites in Bombay, and we are now scaling it up for the country. And this was done on 18th March, 3rd February. We took all the samples and have standardized the method for doing it in the sewage samples, and this has been validated by WHO, and now WHO is going to do it at 20 centers in India for us using this methodology, which is in the Indian Journal of Medical Research. The methodology is at CRESS. In terms of other studies, we have looked at reinfections. As I mentioned about the 100 million test study, HMT study, we have found 40 cases of reinfection in the country. And this paper has gone for publication in Lancet Infectious Diseases, 17 in the age of 21 to 30, 14 in the age of 31 to 40, 2 and 1 more than 60. So, and looking at what is there in the world, Brazil has reported 6 cases. India had reported 6 cases, but now we have found from our database 40 cases, taking the cutoff at 100 days for the first infection and the second infection, and having a infection negativity in between. So this is some data, but reinfection is not a major cause of worry, because it's still 40, even if it is 40 out of 13 crores, it's a very, 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 very small number. We looked at we've established the biorepositories for COVID-19, and the major clinical registry with 38 hospitals has started, and we're collecting data from all the hospitals. What interesting thing that we did at the beginning, majorly in terms of policy, was that we got 15 mentor institutions across the country. We told them that you mentor in your region different medical colleges and different institutions and set up labs. So same mentor institution network we used for the clinical registry. Same mentor institution network we ensured through a gazette notification that all medical colleges get a lab. Same mentor institutions we have used for setting up oxygen generation plants in different medical colleges, and different state governments have been offered money from the PM CARES fund as well as from their state government as well to set up oxygen generation plant. You would be surprised to hear that no hospital in Delhi had an oxygen generation plant as we speak. And now they have been scaled up, and we are going to have oxygen generation plants in more than about 200 hospitals across the country by the end of this month. In terms of vaccine research and development effort started very early. We isolated the virus in March. We gave the virus to Bharat Biotech in April, and they started working on it. They are in different stages of development. We have 15 candidates in clinical research, 25 vaccines are advanced clinical trials, 12 are in phase 2 and 3, 13 are in phase 1 and 2. 5 vaccines are in clinical trials in India, and the situation is dynamic and the uncertainties prevail. We have been reading about it, but India is a world's major hub for vaccine manufacturing with 19 companies with 24 manufacturing establishments. 60%, that is 2/3 of the vaccines supplied to the developing world are from India. India accounts for a quarter of the global manufacturing capacity. So if we are going to vaccinate 7 billion of the world's population, we are a quarter of that. Indian manufacturers are strong in manufacturing with more than 30 vaccines up till now, and they are being supplied to more than 140 countries with 1.5 billion doses up till now. And new vaccines developed from India have been the rotavirus vaccine, purely from India, the Japanese encephalitis, the typhoid, and they've been working on the malaria vaccines. And India's R&D has actually risen to the occasion. So in terms of the vaccines developed in India, we have been very closely working with the Bharat Biotech, and I will be talking about more details how we have worked with them. We worked with Zydus Cadila, with ICMR and DBT, and foreign vaccines that are being worked in India are the Serum Institute, where again, we have helped them with the phase 2 and phase 2b/3 trial for the Serum Institute across different sites in India. And the Dr. Reddy's laboratory and Hetero have partnered with Russian vaccine and Biological E with the USA, and these are being supported by the Department of Biotechnology. Now, we know that there will be multiple vaccine candidates at different stages, meeting scientific and regulatory standards. Most of the vaccines require 2 to 3 doses, 3 to 4 weeks apart, and the length of protection we do not know. It still remains uncertain. We may require a booster dose. Even after vaccination, COVID precautions will have to continue. So this mask will have to continue even after vaccination, and probably this will be the last thing to go, or may even stay forever. Not everyone may need vaccine as pandemic control becomes manageable. This is an important point. What I want to emphasize here is that even if we are able to vaccinate a small portion of our population, some of them have got antibodies, we continue to use masks, we may be able to break the virus transmission. So we may not have to vaccinate the entire population of the country, and we may break the virus transmission. And that is what our goal is, to start with, to vaccinate about 30 crore population by July of 2021. Now, coming to the vaccine development, we know that typically there are preclinical studies, animal studies, which are basically on small animals. They look at safety, immunity, and dosage. Then preclinical studies on monkeys look again at safety, immunity, and dosage. Phase 1 trials are mainly for safety, and phase 2 trials are mainly for immune response, while phase 3 trials are only for efficacy because they are randomized to patient receiving a vaccine and not receiving a vaccine. So phase 3 are randomized trials, while phase 1, phase 2, everyone gets the vaccine, and we look at safety and immunogenicity. Emergency use authorization can happen after phase 2, once safety and immunogenicity is established, and that varies from country to country, whether it be emergency use or compassionate use or extended use, or monitored emergency use, or MURI. So the government is looking at various options, and there are several committees looking at this. We have, in 16 sites, we have done their study on the TADOX, or the Oxford University vaccine. We have also starting the vaccine on Novavax for Serum Institute. So 2 we are supporting in their phase 3. Not phase 3 trials. These are just bridging trials being done in India, clearly to establish that the product is is immunogenic, it is safe, non-toxic efficacy is not being established by these trials clearly. It is only the safety which is being established. The efficacy is being established by phase 3 trials which are being done outside of India for the Serum Institute vaccines. The Bharat Biotech vaccine, we have partnered and we have started the phase 3 trials in India in 29 states, and we will be starting very soon a phase 3 trial in Bangladesh and in Myanmar. This is purely ICMR partnership with Bharat Biotech, and I'll talk about how we have worked on that. This is the vaccine portal of India, which is on the ICMR website, talks about all the vaccine details. Anyone can visit that. So we will talk. Now we developed and a partnership with public-private partnership with Bharat Biotech. We gave them the virus. They developed the vaccine. The candidate vaccine was characterized, studied, and at ICMR NIV Pune. Then we did phase large and small animal studies. And again, I will talk a little bit about how the large animal studies were done in India. And that is another paradigm which we have to look at as a nation. Phase 1, phase 2 trials are completed, 375 and 380 patients, and the dossier is being submitted to the Drug Controller General of India. The phase 3 clinical trial has started. More than 1,000 patients have been vaccinated in their first dose. Now, this was the safety immunogenicity study in mice, rats, and rabbits, and this paper is under the final phases of review in Cell. And we also did the hamster study, which is in the iScience, or also a subsidiary of Cell. It's in the final phases of publication, and we have clearly established the different dosage, 3 microgram, 6 microgram with different adjuvants. We found a robust humoral response, and the T-cell based response was also there, and a rapid viral clearance from the upper and the lower respiratory tracts in these hamsters. This non-human primate study, I want to pause for a minute here, because this was a work which was done at which used to happen in India in the 60s and 70s and the 80s, and this was really wiped out as a concept in India, and primate studies were not really being done. Large animal studies were not being, because of various activists, etc. But what we were able to do at this time was on a war footing. We were able to get permissions, capture the monkeys through the Ministry of Environment. Monkeys were captured. They were taken to NIV Pune. They were housed in excellent air-conditioned cages. We purchased X-ray machines. We did IGRA test of those monkeys. So this was all happening in May, June. Remember, this was all happening in May, June when the lockdown. We did all that. The monkeys were tested for absence of any disease. Then they were injected the vaccine in different doses. Then I had 2 scientists from the CT center at Pune, the Army Center, and one of my ICMR scientists who were DM in respiratory medicine. We sent them to NIV Pune to do bronchoscopy of the monkeys in the BSL-4 facility. And this BSL-4 facility is incidentally the first BSL-4 facility established in 2012 in the Southeast Asia region. The Wuhan lab was set up in 2017. And this is in 2012 that we established this ICMR BSL-4 facility. And there, the monkeys were taken. They were challenged with the virus. Their bronchoscopy was done. They were given the virus with the bronchoscope. And every day, their samples were collected for bronchoalveolar lavage and tested for the virus. And we found excellent neutralizing antibodies, helper T cell response, and complete viral clearance from all body fluids and organs on day 35 in these monkeys which were sacrificed. This paper is in Nature Communications. It has come back to us twice. We had some NGOs write to Nature Communications that why this has been done and how this has been done. We had to provide all the certificates, all the clearances that we obtained to Nature Communication, and now it is in the final phases of publication. So this is another area which India has to develop. And if you look at an editorial which was published in Nature about 6 months back, where China has become the capital for non-human primate study for the world. They have any new drug that is to be developed has to be tested first in China because they have the facilities, or in the USA where it's horribly expensive. So it's much cheaper to get to China and get. So this is an industry which has to be created in India in a huge big way. And we have spoken to the cabinet secretary and talked to the other people to provide this industry or this facilities to be recreated, because they already existed in our institutions in the country, but they were not being nurtured. So clinical trials have been done for the phase 1, the phase 2, the analysis has been done, and phase 3 has been started for 5,600 participants at 29 sites. Um, uh, we also use the BCG vaccination in elderly patients, and we have had 6 trials on BCG vaccination ongoing. We've been able to complete one trial in terms of their 1-month follow-up, and in that 1-month follow-up, this has been sent for publication, and it's available, preprint is available clearly, that BCG vaccination is associated with enhanced innate and adaptive memory cell subsets and increased total antibody levels and potential utility. So we'll have by 6 months, another 4 months, we'll have the data and whether it is working for COVID-19 or not working for COVID-19. However, the 1-month data clearly shows that the antibody response is there. We have institutional mechanisms for the vaccines, and we have the National Expert Group on the Vaccine Implementation, which is being chaired by Dr. Vinod Paul and vice chaired by the Secretary Health, and we are the members. We are preparing all the, right from the vaccine production to the delivery, all the systems are being put in place with the pharmaceuticals, MIT, DGHS, all these agencies working together. We have the Task Force Advisory Group on Immunization advising us on how we need to do advanced purchases, whether we can be doing advanced purchases, and the logistics of cold chain, etc. In terms of partnerships, we've had partnerships with DBT, DST, CSIR, the MHRD, and the Ayush to look at the validation and screening of various antiviral products and onboarding COVID-19 testing laboratories, establishment in biorepositories, and development of indigenous vaccines and candidates. And this has been a project which has been taken directly by the 11 empowered groups created by the Prime Minister's office and the Cabinet Secretary, with monitoring it directly over the National Task Force and the Ministry of Health and Family Welfare, with the state governments, Drug Controller, National Accreditation Board, Emergency Medical Receipt, National Center for Disease Control, NIC, and various state district surveillance officers. And they've worked as Team India and whole of government approach. And a similar, I'd like you to thank you for your attention at this point. A similar story is available for how oxygen has been scaled up in the country. Similar story is available for how hospital beds have been scaled up in the country, and how various ministries have worked together to scale it up. Thank you so much for your attention. I'll be happy to answer any questions if you have immediately.
Thank you so much, sir, for the presentation. Kudos to you and your team, ICMR, for all your efforts in addressing this national health crisis. My question to you is, you've just told that this health emergency has taught us many important lessons. So what, in your opinion, has been the single most effective step taken by ICMR to combat this crisis? And can we do anything differently in the second wave or in the future?
I think I have told what ICMR has done. The most important step that we have learned is that we can, if we talk about differences of interdepartmental, inter-university, intra-city, intra-state, and work as a nation, as Team India, we can do it. And the magic there, and that is why when it was top down, it really worked phenomenally well. And that is why I would like to emphasize that ICMR, being a 108-year organization, has a system in place, has a hierarchy in place, which has worked phenomenally well. And I find I'm being some second waves in different parts of the country, 7, 8 states are we seeing the virus resurface and show its head up again. But we have to continue with the measures of using the mask. I would say that mask is a cloth vaccine or a fabric vaccine, and I've sent an editorial on that. That's a fabric vaccine, and that will have to continue. And if you look at many of you who have visited Tokyo, I mean, in the 2008, 2009, 2012, even in the streets, people used to wear masks in most of Southeast Asia. Because of the H1N1 and the pollution in Tokyo, they used to wear masks. And I think that will be the new norm, that we will have to continue the mask, and masks will probably be the last to go, or as I said, that it may never go. So this will provide 30-40% protection. I do not know what percent, but it will provide good protection. The vaccine may provide some protection, and some people who are oddly infected will be protected. So if we are able to reach a critical mass to break the virus transmission, I think we should be able to win this war. But it's tough. It is tough. We are still working, and the presence of the vaccine does not mean that we give up these measures of wearing the mask and social distancing and doing avoiding non-essential work. I think that is the most important.
Thank you so much, sir. We may have to go for a second lockdown as in the West.
I don't think, from what I understand, I don't think we will have to go for a second lockdown. Here again, I have a hypothesis, and India is a young democracy. It is only 70 years old democracy. Countries in the West are 200 years old democracies, and they feel, I don't care. That attitude is developing in India, but it's still very young.
Thank you so much for your wonderful presentation, sir. It's been a pleasure to have you on board.
Thank you so much.
And with this, we move on to our next presentation. And our next speaker is a doyen from the corporate healthcare system, Dr. Naresh Trehan, the chairman and managing director of Medanta, the Medicity. We all know that he's a world-famous cardiothoracic surgeon and a recipient of the coveted Dr. B.C. Roy Award, Padam Shri, Padam Bhushan, and so many other awards. And today, he would be speaking to us on synergizing role play between public and private healthcare systems. So over to you, sir.
Thank you. Thank you. It's a real honor. To start with, I consider KGMU my professional birthplace. So it's never away from my mind. And whatever we have done or reached or whatever learned is basically from the shoots or the seeds that were laid at KGMU. So eternally grateful to that, and it's an honor to be with the Vice Chancellor, the other speakers. Dr. Balram Bhargav has already laid the whole scenario of where we started, where we are, where we hope to go, and it's just quite scary with the fact that the realization, which most people did not realize, that even when vaccine is there, it may not protect you from getting infected, but your symptoms may be less. So these are all clarifications which come as we go downstream, but that comes back to the whole thing that when COVID came, and thanks to China and their concealing the fact, which we should all be very angry about, that there was very little infrastructure, very little equipment required to be able to fight the deadly virus, and especially the fact that if it was going to follow the example of Italy, Germany, we would be in serious trouble. So the Prime Minister immediately clamped down that the lockdown, which was, I think, in my mind, there is no controversy over that. It had to be done. He did it. Great. And that flattened the curve, giving us those 3 to 4 months to actually prepare the infrastructure. And I must compliment the government on that they broke down all barriers between private healthcare providers, with the government, all the providers in the government space, the industry, because this was a magical moment when everybody came together and, excuse me, and gave India much relief from importation of PPEs. The garment industry repurposed itself immediately and provided at a fraction of the cost of what the Chinese were extorting from us. The N95 masks of great quality, and more importantly, the ventilators. And you could see what happened. Like, we were working with the company Agua to actually perfect their models, and then came the COVID, and Maruti came into the thing to scale up their production. And there was another couple of people in the south, and the Tatas helped, Mahindra's helped. So we are not only sufficient in all these things, but we are also exporting now. So that shows the, the, the strength and the resilience of India, that you can actually so rapidly do what you have to do. So this also proved that the government and private sector work together beautifully, worked well, and are continuing to work. Because the burden that with our population and the burden of we have three burdens right now. Before you had two dual burdens. One was the communicable diseases, the other was the lifestyle or non-communicable disease. Now we have the third member of our challenge. Okay, and we don't know because just about a month ago in the Delhi area, NCR area, we thought that we were winning the battle. Things were coming down. Delhi showed, I think, less than 200 cases one day, or like at least for less than 1,000 cases had become the norm. And now suddenly it's gone up, highest ever, 7,000, 8,000. So these waves are coming, which are giving us a great warning that the war is not over. But so if you take the government, which did all that good, I think the private sector also took the lead in their area, provided the much needed ICU beds and the beds. But at the same time, the third arm of this whole fight is the public. Unless the public adopts the whole warning signs that have been given, and Dr. Balram Bhargav just repeated those three things, that unless we have universal acceptance in India of the public's responsibility to fight this disease, we will have an uphill task no matter how much science we produce, how many facilities we produce. It's going to be a miserable state. Because the misconception of that they'll all survive, these are all myths. We have seen enough young people die. We now know that how many people are suffering from post-COVID syndrome. It's not something that's so simple. It's not something you don't care because you're young, you invite. This message has not gone deep into the society yet. And I think we really need to repurpose our communication into saying, masks and all that, but also putting the next step that how many people are suffering so badly and will continue to suffer maybe for their whole life because their lungs are destroyed. So I think that arm is missing. The government and the private providers and the frontline health workers have done a fantastic job. There's great coordination. Government is coming down with protocols and measures regularly. I must say that this battle that is being fought by the government is, remarkable. It shows how integrated services can work. Okay, but that Balram has stressed already, but I will tell you that what is the challenge on the private side. Okay, there's some disturbance here. Is that disturbance on your end also?
We are having some disturbance. We'll ask the Dr. Sheetal, we would request you to please mute yourself. Dr. Sheetal, requesting you to please mute yourself. Yes, sir. Please. Sorry, sir.
Okay. No, that's okay. So what happened was that there was some distress or a lot of distress in the private sector because the rates fixed for treatment were not covering the cost. So there has been a lot of loss of money by the private sector, especially the bigger institutions. But that aside, we will survive. That's not the problem. The problem became for the non-COVID patients. The non-COVID patients are the ones who have suffered in this whole malady, because like hospital like ours at least have enough capacity and separate areas, so we can have two separate towers, one for COVID and the other for non-COVID. But if you look at it, if you step down, smaller hospitals have had a problem, and people are very scared to go there. They postpone their surgeries, they postpone their treatment, and have suffered. So I think that as doctors Bhargav and others have warned, that this may not go away so fast as we think. That even when vaccine comes, there will be a lag period. That we need to prepare ourselves how we are going to take care of the COVID and non-COVID in a fixed protocol, developed so that the public can have confidence that they can come for their treatment to hospitals that are exercising this kind of separation, segregation, or safety features. So I think that's one thing that we need to look forward to. Hopefully, the tapering will go on, and we will not experience a third or a fourth wave. Hopefully not. This, what we are suffering right now, is possibly from the festive season, from Diwali and the one before that. So I hope that it will taper off, and in the coming couple of weeks. But more importantly, I think that the private sector has been quite happy, responsible, participating in every way, and I think they will continue to. But the only thing is that the government may help to tide over this financial crisis which lots of hospitals are facing by giving them certain relief on the interest rates on the loans they take. This is something that can really help the public, the private sector to fight this fight that may go on for several more months or a year or two. We should be able to give them some support. There doesn't have to be any grants, but just low-cost loans will be a great help in their ability to keep fighting along with the government facilities for the long run. That, I think, would be important. Now, the point is, we know about vaccination, we know about everything else. We need to know that if we are going to repurpose ourselves, all of us, to participate in the challenge. We know the requirements. We don't know which vaccine will come first, what will be the requirement of the storage and transport medium, but there is one truism that all of them are going to be injectable. If that is injectable, who are the people who will be on? Who are the people? And we, like the Health Sector Skill Council, we have started programs to skill many people, not only for the skilling of administration, but also assist the people. So if a doctor or a nurse who's authorized can give, in 20 seconds can give a shot, and it takes 20 seconds to draw it from the multi-purpose vial, somebody else could be doing that. So if we enhance, and I'm sure Dr. Bhargav and company have already put a lot of attention into it, but it needs to be disseminated to enhance who are the people who we expect will participate in this, and is it too early to actually declare that chain, or should we start working on it right away? I think that's basically the next challenge that we are facing, and we will all do it together. So thank you very much. That's all I could add to because everything that you know about COVID has already been said.
Thank you so much, sir. You have actually raised very pertinent issues. I have a question. We all know that the private healthcare sector has always been a very important pillar supporting an overstretched public healthcare system in India. Why do you think the private sector was a little late in pitching in to help and support in the beginning of the pandemic? And do you think the formidable cost of treatment in the private sector can be brought down in some way?
Okay, so I don't know where you got the idea that the private sector, we are the first ones to take the 14 Italians who were discovered in Rajasthan. From the PMO, we were asked to take care of them. So we got we jumped into it very early. And since then, we have been absolutely committed. Okay. Yes, there was a lot of confusion, which I'm trying to tell you, that what happens, a facility which to run on a daily basis, when you add treatment for COVID, you're talking about the PPEs and the staff being rotated, because then they can only work 30 days. Out of the 30 days, half the time, because then you rotate them out. A lot of them will get sick. We are have a government, the rates were a little more realistic. That's why who we said, okay, it's our responsibility. We have the resources, we have the number of people because we have 1,200 beds. We jumped in. We have no hesitation. But I can understand some of the other people who, because how much money can you lose? We have had to borrow every month to pay our salaries because the non-COVID were down. But we don't want to. The doctors came together, volunteered to take less salary. All that happened. I don't think.
Dwarika, New Delhi. He's a reputed nephrologist with innumerable publications and awards to his credit, including the Vishisht Seva Medal and the Chief of Naval Staff Awards and awards to his credit, including the Vishisht Seva Medal and the Chief of Naval Staff Awards.
And Professor Trehan. Professor Bhargav brought out about
Sir, sorry. Sir,
Yeah.
सर sorry for interrupting. Can you just mute your my phone जो आप साइड में देख रहे हैं ना, जिस पे आप व्यू देख रहे होंगे, उसका स्पीकर थोड़ा सा आप धीमा करते हैं सर.
Well, from Indian scenario and public-private partnership, I'll dwell to only hospital setting and concentrate on dialysis population. Now, this population may be one of those immunocompromised population which you may encounter like in cancer patient or cardiovascular patients or other patients. Now, let me start here. This is the scenario of COVID as on today. We have all learned that there are 61 million cases worldwide with almost 1.5 million deaths. If you go to the original paper from China, and that data of almost 72,000 patients true today, we all know that with the incubation period of 12 days, maximum of 14 days, the usual presentation of a COVID patient is with fever, cough, myalgia, and fatigue. Almost patients present with fever and two with cough. Also, that 80% patients have got mild disease, 15% severe, 5% critical disease. Now the question is, who are the people who are going to develop severe or critical disease? Now, these are the people who have got two issues that are important. One is, just a minute. The one is that people who have got comorbidities, whether it is hypertension or diabetes or coronary artery disease or cerebral vascular disease. If you look at the US data initial, they found that 99% of the patients who died had underlying illness. If you look at the Italian data, it's similar. Almost 98.8% patient had one, and almost 50% had three or more comorbidities. So having comorbidity is one of the very strong risk factor for developing COVID serious infection. And this is again a data which is only telling that if a person has got cardiovascular disease, he is 10 times more prone to develop severe disease, diabetics 7 times, cancer patient 5 to 6 times, likewise CKD patient 5 to 6 times more vulnerable to develop severe or fatal disease. The second point is the age. If you look at the world population today, the maximum aging population is in Japan. 18.5% of the population is over 70-year-old. Now, this is the data from China, which clearly showed that as the age keeps going up, the risk of death keeps going up. For people over the age of 80 years, almost 15% mortality is recorded. Now, fatalities in Italy were almost 13% because they have got the second largest elderly population in the world. Mind you, 23rd%, almost 1/4 of their population is over 65 years. And the similar figure, if you look at Italian deaths, 83% patients who died were over the age of 70 years. Even US data, you find all deaths in New York, 2/3 were over 70 years and 95% were those who were of age more than 50 years. The Spain is no different. Similarly, as the age keeps advancing, the risk of mortality keeps increasing. Now, CKD patient, our dialysis population is vulnerable because first, they are all immunosuppressed. Number two, they have got comorbidities. As a matter of fact, 95% of dialysis patients have hypertension. Today, almost 40 to 50% of them are diabetics also. Almost similar figure they have got, which came out, the French Renal Epidemiology and Information Network, which shows that if the COVID prevalence was 0.2% in France, the dialysis population was 17 times more vulnerable, was 20%. If you go to European data, and the European, they did very well. They started collecting data from all the European countries. Again, you find approximately 20% mortality due to COVID. If you look at the diagrams, you find from different countries, from Austria, Belgium, France, Romania, Spain, but our countries, you find that if you follow the graph, approximately 20 to 25% of patients by the time of 28 days, they develop, unfortunately, fatality. And the picture in transplant patient, I have purposely put this graph that in transplant patients also face a similar problem. So if you look at the figure again, that possibly by day 28, 20% are more patients. The second aspect which I want to highlight. First, we have said that presentation by and large is with fever, cough, myalgia, and breathlessness. Look at this outbreak in urban hemodialysis center. 11 out of 237 patients developed COVID. They were tested positive, and 11 out of 93 staff, 12% were tested positive. What is bad or difficult is 55%, more than 50% of them, when they were tested, were asymptomatic. That is a killing problem. That most of the dialysis patients come, they do not manifest with. Look at this is a out of which 419 had end stage kidney disease. Let's come to the cartoon. This is the data that over 10,000 non-dialysis population and 419 dialysis population from almost 27 centers from US. What you are finding that even after adjusting for all the risk factors in two groups, you find that dialysis population has got almost 38 or 40% higher mortality. The patients who had higher having increased age, required mechanical ventilation, had lymphopenia, and increased bun or ferritin level. This is the data from India. There's two centers in Bombay. They publish data, and the picture is almost similar. One third of the patient remained asymptomatic, and another 21% had very mild disease. So that means more than 50% patients, it may be difficult to find out that they are having COVID. And mortality, again, 38%. This is the recent, it's unpublished data. Now, people started universal testing. This study of nine dialysis centers from Mumbai, all the 705 dialysis patients in these 9 centers and 103 dialysis staff were tested, RT-PCR was done. And they found 7% and 14.5% prevalence higher in staff vis-a-vis the dialysis patients. What they found, after 2 months of this testing, they tested the antibodies in all patients, whether these patients had developed antibodies or not. And what they find that 16% additional patients and 37% additional staff members who were RT-PCR negative before had developed antibodies, just suggesting that the subclinical infection was ongoing, a quiet infection was ongoing, so therefore they have developed antibodies also. So that is a point. Is universal testing required? I think Professor Bhargav is the right person, but I will say no. Because This can give you a point prevalence at one point of time, but overall, you do not gain much data. This may be useful if you are suspecting an outbreak in a particular setup. Then you may test it, but otherwise, it should not be done as a routine. Now, I just analyzed the data when I was writing the commentary for this article. I collected the data from Sir Gangaram Hospital, Max Hospital, Medanta Medicity, and our center. And again, we found that 12% of our dialysis patients are positive, and mortality was again similar, almost 20.9%. And again, there's another report of over 1,000 patients from 27 dialysis centers in Mumbai. With a follow up of 3 months, they reported 6.74% the COVID positivity and 12% mortality. Mind you, the difference in figures is always because what we are measuring these days is a period prevalence, not the point prevalence. Now, like our data is for last 8 months. Logically, you are going to have a higher prevalence and maybe higher mortality. And if your center is doing a study for 1 month or 2 months or 3 months, the figures have to be different. So keep in mind the figures will keep changing because we are talking about period prevalence. Now, if you look at the peritoneal dialysis patient, our home dialysis population, now the difference is only these people do not have to come to hospital and they do not have repeated exposure to the hospital. What you find? That the PD population was not at high risk for COVID-19. This is a difference. So one of the important factors in dialysis population, which possibly is in some of the other patients like cancer who are coming daily for chemotherapies, the repeated exposure in the hospital environment is giving a higher risk for infection. Now, lastly, I must mention that Professor Bhargava had mentioned about the ICMR. Things the ICMR, they adopted what we call the Indian Society of Nephrology guidelines. They are similar to guidelines. Number one is screening and trial and this is what we practice. That before a patient enters a dialysis unit, or a dialysis unit setup in a separate room, every person has to be screened, a history has to be recorded, examination, local temperature has to be done, and if required, regular testing should be done. We do not allow any accompanying person now in the dialysis room. We do not serve any refreshment in the dialysis room because that requires opening the mask. And there has to be a separate room or shift for COVID positive or suspected patients. It may not be possible for every dialysis center to have a separate room. If you don't have a separate room, you can run a separate night shift for COVID positive patients. Even if you don't have that, maintain a distance of at least 6 feet. You can give a corner bed to a person. But mind you, the staff who is caring for such people have to use PPE. What is important and heartening, I think the lot of stress, the fabric vaccine and whatever has been said, which is absolutely true. You'll be surprised that for 8 months, all my dialysis staff has been using N95 mask. Mind you, though we had almost 20% prevalence of COVID infection in our dialysis population, none of the staff has developed COVID, even despite testing, which is only because they are using mask. Now, these are again the CDC recommendation, which are alike universal mask, routine screening of symptoms, specified treatment area and protocol for those who screen or test positive, reduce crowding in waiting room and staff break rooms, and testing asymptomatic patient and staff in times of higher community prevalence. Another important point uh, is that during transportation to and from dialysis, there should be reduction of the shared rights and mandated sanitation protocols must be followed. And these people, when they are living in the community, engagement and education of patients and families on risk and risk mitigation needs to be practiced. and expanding testing in high risk setting if you are finding congregate residences or neighborhood with high community prevalence, maybe the testing will be required. I think I'll stop here just to mention a slide that during lockdown period, this is an Indian data from 19 major tertiary care institute, a lot of them from Delhi, that 28%, almost a quarter of patients missed one or more hemodialysis session because either they were not able to come or there was something in the family which did not allow them to come, and many of them required emergency dialysis sessions. To summarize, dialysis population is a very vulnerable group, like many other vulnerable groups. A lot of these patients remain largely asymptomatic. Our presentation may be atypical, but mortality is pretty high. So therefore, we have to keep high index of suspicion in our mind and keep the threshold for testing should be low. Before entry into the dialysis center, screening and triage is mandatory, and I believe I'm very happy to say that most of the institutions in India are following this. The strict observation of precaution is the only preventive strategy. Every center has to devise its own working plan for prevention, whether you have to use PPE, mask certainly is mandatory, distancing between beds, eye protection. This is the ICMR has recently paid attention to uh, goggles, eye goggles, that there should not be a gap between eyes and the goggles. Hand wash, whether with soap and water or by alcohol, are universal precaution. There's a reduction. Thank you very much. I stop here. Once again, thank you very much, General Bipin Puri, for this invite.
Thank you so much for a very elaborate presentation. I have a question for you.
Yeah.
We've all seen that acute kidney injury is actually emerging as a very common complication of severe COVID infection. In your view, what could be the long-term impact of kidney involvement in COVID survivors? Do we actually have enough dialysis facility to cater to these demands? Or do we have to do something proactively for it?
Very difficult question, but very correct question. As you rightly said, when we go to our COVID ICU, like today, every hospital has got over 100 patients of COVID in ICU. Every time, every day, you come across, if you have to look at overall picture, it is different. But if you look at the ICU figure, almost a quarter of them require renal support. AKI is pretty common entity. Now, the etiology is multifactorial, whether you say the drugs, whether you say the cytokine storm, whatever the reason, whether you call dehydration, whatever. The reasons are multiple, but this is a definite entity. The problem is whether we have got enough. Possibly, we have got in corporate hospital, you have got the facility. But a common person, what he requires, I personally feel the opportunity for him to have this are little on the lesser side. We can offer a CRRT or any form of dialysis to the patient. You know that even in developed countries like US, where at the peak of the COVID times, there was deficiency of dialysis beds and people had to resort to peritoneal dialysis. Even in US, where they never practiced peritoneal dialysis, people started using peritoneal dialysis because the equipment and the disposable became less. So there is need to augment these, no doubt about
Thank you so much, sir, for taking out time and for being with us with your wonderful presentation. So we would move on to the next presentation for today, and our next speaker is Dr. Santa Sabuj Das, a very renowned immunologist and vaccine expert working at of Biomedical Informatics Center of ICMR at NICET. And although he was trained in clinical medicine, he has devoted his entire life to research and has been working on host immune response and vaccine development. So today he would be enlightening us on a very interesting, even though it's a bit controversial topic of herd immunity versus vaccine, what would be the savior? So over to you, sir.
Thank you for your kind introduction. Now, so is my slides visible? That has always been a problem, when
Not yet, not
yeah,
yet.
yeah. So just a minute. So I go to, but it says you are presenting. Do I need to do it
Yes,
again?
now I think now we were able to see your first slide. No,
Oh,
it's
you
not.
are? Okay,
No,
okay, just a minute.
not anymore.
Yeah,
Not
yeah,
anymore.
just a minute. So slide আমার कोई slide? So are you able to see it?
Yes, now we can see
Huh?
it. Yes.
Okay, okay.
If you
Thank
can
you.
do on the full screen mode, sir.
Yeah, yeah, sure, sure. Yeah. Okay.
Perfect. Perfect.
So now, yeah, there were really fabulous presentations by these eminent speakers, Professor Bhargav, Professor Trihan, and then Professor Varma. So, uh, I'm not sure whether I'd be able to live up to the expectation of the audience who have been listening to these presentations, but I'll try my best. So the my topic would be, it's a bit of a controversial topic, that the topic of herd immunity against COVID-19, and whether we should go for to achieve that herd immunity, which will eventually protect us, uh, or we definitely need a vaccine, and that is an highly effective vaccine. Now, the herd immunity basically, can be achieved by both by natural infection and a vaccine. Okay. Now, its appeal is quite understandable because when there is the herd immunity is high, then there will be less. The epidemic actually stops. But for COVID-19, disease like COVID-19, it will come at the cost of a lot of people falling sick, and mm, and a lot of deaths also. And moreover, this herd, the terminology of herd, may be kind of unacceptable to many people, because as we all know, herd actually refers to domesticated animals, particularly livestock, which are used for human consumption, uh, human food. So Raj Bhopal from London has preferred a term population immunity rather than herd immunity. And in fact, herd immunity first appeared in the veterinary world only. There was in the early 20th century, there was an infection. There were actually multiple epidemics of spontaneous miscarriage due to a contagious abortion. And what people used to do is to sacrifice those animals and get new ones, and which would eventually get infected, and then again, you know uh, they had to be sacrificed. So Adolf Ecorn, he actually first suggested that this practice should be stopped, because this is like a fire. If you do not add more fuel, the fire will be automatically doused. So uh, he said that go for the immune cows, and raise the calves, instead of getting sacrificing them and getting replacing them with new ones. But he certainly did not use this term, but that was a concept that he proposed, which is actually a herd immunity concept. And then it was experimentally described by Topley in mice, uh, creating epidemics in mice. And from the veterinary world to the medicine, the clinical world, it moved with the appearance of diphtheria and scarlet fever epidemics, and then it became increasingly popular with other diseases like influenza, polio, smallpox, typhoid. Um, it became a kind of talk of the medical community and general population also of that era. Now, there was a fresh prominence. Now, these were all through natural infection, but there was a fresh kind of resurgence of herd immunity with the appearance of vaccines. And then the question, the public health communities or experts raised the questions that what should be the vaccine coverage to achieve herd immunity. Um, Now, this has continued, particularly with in the 90s, late 80s, early 90s, mass vaccination drive. This question, haunted the scientific community that what should be the ideal coverage, and we realized that it might vary from one disease to another. With COVID-19, what came to the forefront is because we do not have a vaccine, so it's a hard immunity through infection. Okay, so whether we can allow the people to get exposed to the infection, particularly those obviously who are sufficiently young without any comorbidities or immunosuppression, so they get a milder non-lethal disease, and then eventually the population gets protected by herd or indirect immunity. Now, this concept, although at the beginning of the epidemic was raised, but eventually our experience from the Europe and Scandinavian countries actually showed that um, despite community transmission and a lot of people falling sick, there was less than 10% seropositivity. So it was practically Lancet concluded that this would not only be unachievable, but it would be unethical also to expose people to this infection to achieve the goal of herd immunity. But the proponents of herd immunity, they persisted. They their arguments were that the seropositivity may not be, so the antibodies may not be essential for our herd immunity. We require T cells, T cell immunity, which is induced in vast majority of the infected population. And also, if the most uh, uh, if the most susceptible members of the communities are infected first, then although there will be more casualties and more severe disease, but the more resistant ones are left behind, and then we could get possibly achieve a herd immunity with much lesser population being infected. Okay, but obviously, I mean, letting the most susceptible population to get infected is not a good idea for sure. And so this like what could be the threshold, okay, which will give us herd immunity, so which is called herd immunity threshold. Okay, so that question came back again and again. uh, and so this threshold is basically it arises because population, susceptible population is benefited by, because it is surrounded by an immune population who got naturally infected and developed immunity. So and this is, as we all know, that for an immunizing infection, strongly immunizing infection like COVID-19, at least initially, there is significant immune response. So the determinant of herd immunity threshold can be determined by R0, which is the number of new infection generated by the first infected individual in a completely susceptible population. And so this immunization threshold is, which is equivalent to 1 minus 1 by R0. For COVID-19, it has been calculated considering the R0. The immunization threshold was calculated around 56%. And with then taking into account some people will die and all these things. So it came around 60 to 70% population has to have the immunity, obviously at this point through natural infection, to get herd immunity. Okay, now uh, however, the unique threshold is unlikely because this R0 calculation is accepting a homogeneous mixing and uniform birth rate. So if these things vary, so if the birth rate is high, then there will be the immunization threshold will go up. And obviously there will be non-homogeneous mixing based on age and other things. So there will be, even within a population, it will not be very uniform. So now the question of T cells in herd immunity. Uh, so as we have seen, so the why the question of T cells have come up, because what we have seen with the antibodies, that one is that low seropositivity of the infected population. Second is antibody persistence of antibodies. Okay, so that there are reports that antibodies are persisting only few months and then going down, and also it's not certain how much of these antibodies are really neutralizing the virus. So all these things have brought the role of T cell in the forefront, particularly the memory T cell, because if there is sufficient memory T cell is generated, which can provide, which can itself handle the virus in some way, and also provide help to the generation of antibodies by providing help to B cells, and also that is called cytotoxic T cells, which are important for antiviral immunity. So both these cells, B cells for antibody production, cytotoxic T cells for direct killing of the virus infected cells, both require help from this type of memory helper T cells. So I mean, it's a very simplified presentation. So we have naive cells, that CD4 or CD8, and they produce different types of memory cells. They are like uh, central memory and effector memory. They are the circulating memory cells, but they come into play a little late. They take time to act against the infecting pathogen, and what's more immediately is the tissue resident TRM, tissue resident memory T cells. So if they are present, so if there is an infection in the lung by another coronavirus, because we have found studies have found that there is significant number of cross-reactive memory T cells present in the COVID-19 infected population from other coronaviruses, like most likely from the common cold viruses. Okay, so those cells are present, but they are mostly uh, CD4 plus memory T cells, not CD8 plus memory T cells. But they're mostly CD4 plus memory cells. So on the contrary, the presence of antibodies, particularly neutralizing antibodies, cross-reactive neutralize. So these are cross-reactive memory T cells. Cross-reactive neutralizing antibodies are extremely rare. So uh, that's why we perhaps require more of a T cell response for a long-term control of this, and for herd immunity particularly against this virus. And and then there is some T cell, these are follicular helper cells. They are very important for generation of the antibodies, so to provide help to the antibodies and generation of neutralizing antibodies. So uh, what so there are several possible scenarios for the impact of this cross-reactive uh, CD4 plus memory T cells. So like say if there is no cross-reactive memory T cells, so this in a population which gets, so there is a new infection, there is no past infection with or past memory of a coronavirus infection. So we get a high upper respiratory infection, high lung infection as well, lung viral load. But the mostly there is a symptomatic disease, severe symptomatic disease, high upper respiratory infection, lung infection eventually is protected by the immunity that is generated with the new infection. So lung viral load is decreased. But for community transmission, it is the upper respiratory viral load that is most important. So it doesn't stop community transmission. So the absence of a pre-existing cross-reactive memory T cell has little effect on transmission of the disease. Now, what if there is a um, cross-reactive T cell present in the population or the individual? So in that case, what we find is that uh, there is lung burden is further reduced, but uh, basically the upper respiratory infection is still not much reduced unless this cell, which will come in the next slide, this cross-reactive T cell is a particular subset of T cells. So if uh, it's not that subset, so we do not get much of a reduction in the upper respiratory viral load. But obviously, the symptoms are decreased, and as well as lung viral load is decreased. And for a population, there is, because it is less symptomatic, so less probability of hospitalization and deaths, but there is no reduction in viral spread, and it might actually be increased because of less symptomatic disease. Now, if there is a high level of uh, TFH cell mediate accelerated antibody response, if that is a scenario. These are all hypothetical scenarios. So if there is a TFH cell accelerated antibody response, as I mentioned, that this follicular helper cell, they are responsible for this antibody generation, and so they provide the help to these B cells to provide antibodies, particularly the neutralizing antibodies. And we can see that in addition to lung viral load, actually there is the upper respiratory viral load, although not initially decreased, but later on, so the duration of upper respiratory viral load being present is reduced. So, and then obviously, if this is there, there will be robust immune memory generated. Um, so we will get fewer hospitalized patients and fewer deaths. And there would be a modest reduction of viral spread because of decrease in this upper respiratory viral load in the later part. And if there is TRM cells, so tissue resident memory cells, which come immediately into action when there is an infection. So if that is present, what we can see is that there is significant reduction in the upper respiratory viral load, and the disease might be even asymptomatic, and lung viral load might be very, very low or undetectable, because the tissue resident memory cells will immediately provide help to the B cell to produce neutralizing antibodies. So now these scenarios actually what it suggests is that um, what we require. So this is, so these tissue resident, these cross-reactive memory T cells, they are actually giving us some idea about uh, who can have, so even with natural infection, there will be variation, there will be heterogeneity in hard immunity, and also, like, if we have a vaccine, what kind of vaccine we will be actually required, what kind of T cell response that this vaccine should induce to have a lasting immunity. As I just mentioned, that the antibody response is probably not optimal for a um, for stopping this epidemic. So a vaccine, an ideal vaccine, uh, would probably require to induce T cell immune response, and um, and at the same time, this has to be regulated T cell immune response, because if we have a so this vaccine thing is that the white T cell immune response would be better. Now, the vaccine, the antibodies would have multiple shortcomings, could have, like say antibodies will, as we have found, that doesn't last very long without T cell help. This is one. And number two, we know about ADE phenomenon. So this is possible, and some reports have come up where more severe patients from ICU admitted patients have higher level of antibodies. So that is either it is non-protective or it is counterproductive. Productive. Mm, and so um, and what happen, and again another thing is that if the virus mutates, which RNA virus does, so there is every possibility that the antibody epitope against which the antibodies are generated, the epitopes against B cell epitope against which the antibodies are generated, they will not be effective against the mutated virus. So down the course, the antibodies might not work, the vaccine might not work at all, or have reduced efficacy. So the benefit of T cell, particularly CD4 T cell mediated response, although CD4 T cell directly doesn't take care of the vaccine, it works through the B cell or through the CD8 cells. But there is um, there are more conserved epitopes and fewer epitopes that can be chosen against which these CD4 cells may be generated. So the chance of vaccine being ineffective due to viral mutation is less. Number two, as I said, the memory response will provide long-term protection. And but there is a caveat, is that uh, as we know that this there is uh, Th1 predominant response in COVID-19. So the one on one hand, it could be useful, this Th1 response, uh, because this is the Th1 response that actually provides help to these CD8 T cells, and Th2 is providing to B cells for antibody production. So this so that is one way it will produce more cytotoxic T cells, which will kill the virus infected cells. But on the other hand, we know about cytokine storm, and they are basically the Th1 cytokines like IL-6, TNF alpha. So uh, that is one thing. And another thing is that what was found is that that in there was lesser number of um, regulatory T cells, which actually are important for controlling the damage to the lung in the more severely infected patients, particularly ICU admission, ICU admitted patients. So although they have a very robust CD4 T cell response, more specifically Th1 response. So that is one thing that has to be kept in mind, that we should have a balance so that it doesn't alter the balance in the local area, so that there is very severe Th1 response leading to uh, more damage to the lung. And at the same time, we need to choose epitopes in a way so that there are more of a tissue resident memory cells, and uh, follicular helper cells are generated. So I think we have to uh, go a long way now. We have, obviously we need vaccines for immediate use. We really need some or other vaccine which will be which will give some protection. But uh, whether these vaccines will eventually be the ones that are expected to be immediately coming, whether they will be sufficient to stop the epidemic, um, we are still not sure. There are many other vaccines are in the pipeline, so eventually we might be getting more tailored vaccine, which will be generating more of a memory T cell response to provide long-term protection. So with this, I would like to stop here, and I'd be happy to answer any questions.
Thank you so much, sir, for discussing this controversial topic about herd immunity versus vaccine induced immunity, the role of T cells and B cells, and other things. My question to you is
Yes.
actually back to basics.
Yeah.
I would just like to know from you, what do
Yes.
you think is the current level of herd immunity in our country? And in view of reports of cases of COVID reinfection, do you think these vaccines, the vaccines that we are going to get in the near future, would actually be a game changer in the pandemic, or we have to wait for the tailored vaccines that you were discussing about?
Okay, this is a very, very important question. So the first part was what? Second was obviously the current vaccine. What was the first question? First part of the question?
I
Uh,
wanted to know what do you think is the level of currently the
okay,
level
level of
of
okay,
immunity
level
in
of
our
right,
country?
right, level of herd immunity. Yes. So what the serosurveillance that ICMR has done, which has showed around sero prevalence, um, overall sero prevalence is around 1%. Okay, although in the high infection zones, it was much higher, like in major cities, it varied from 20 to 40%. But uh, whether is in that is providing herd immunity, um, well, as of now, personally, I'm not very sure whether they are, because if you look at Delhi, the last sero surveillance suggested more than 25% sero positivity in Delhi population, and then we are getting another second wave and so-called third wave in Delhi. So, and whether these, how many of these people they still have the antibody, and how many of these antibodies are really protective, that we certainly do not know, those who are infected. Reinfection, on the contrary, chance of reinfection, maybe in the immediate future, the chance of reinfection is low after infection, but there are the even few reports that have come up. They are worrying. If people get reinfected after a few months, that means at least in some population, the antibody is not persistent or not providing protection. Okay, so that suggests, further strengthens that we perhaps required more of a tailored T cell immune response or memory response generating vaccine, um, for long-term protection and really, end the epidemic. But yes, whatever vaccine we will be getting in the near future will certainly protect populations, particularly the high-risk populations, the frontline workers, healthcare workers, and comorbidities, people with comorbidities. So any vaccine is welcome, but whether that will be uh, kind of solve our problem forever, um, I am not sure. I presume that a T cell memory response inducing vaccine would be eventually required.
Thank you so much for your wonderful inputs, Dr. Das. And with this, we move on to the next presentation.
Thank you
We
very
all
much.
know that aggressive testing has been the backbone of COVID-19 management. So we now have Professor Amita Jain, a renowned microbiologist heading the Department of Microbiology at King George's Medical University and the nodal officer for laboratory technical support in COVID testing for UP with us today. And she would be sharing her experience in her about her contribution in this epidemic in her talk on 60 to 6,000, an unimaginable journey. Over to you, ma'am. For your kind words, and I thank organizers, for the opportunity. Uh, I bring you greetings from King George's Medical University, our alma mater. Start the presentation. So here I bring you the greetings from KGMU. 60 to 6,000. These are actually the numbers where we started testing at 60 and have reached to 6,000 tests per day. I'll be in next 5 to 7 minutes. I'll be sharing with you our journey as a microbiology laboratory. Most of the things which I'm going to say have been said by Professor Bhargav. Thank you, sir, for covering everything so beautifully and in a lucid manner. The pandemic of COVID-19 is a public health emergency of unprecedented scale. We have never witnessed any public awareness of this magnitude for any disease ever before. Definitely, it's needless to say that there was a stress on every element of public health, including diagnostic laboratory systems. Also, we are aware that political commitment was needed to boost the diagnostic and healthcare capacity of the country, and which was provided, which we all have witnessed to its maximum. The national need for quality assured testing for everyone was felt. This was important to decide the line of treatment and to stop the transmission of the disease. We started testing from 3rd February 2020 under the guidance of Indian Council of Medical Research. At that time, KGMU lab was the single lab which was authorized for COVID-19 testing in UP and was one of the 13 labs in the country. That time, our declared capacity was 72 tests per day. When we witnessed the first few cases in March, first week in UP of COVID-19, Honorable Chief Minister himself took a notice of it. He called a meeting following which a lab network remember the date, it was 23rd of March when we started expanding our capacity. The journey was not easy. It was not a straight path. It was very complex. We had to have a multi-pronged approach, and it was like a maze. The three fronts on which work has to be done. One was increase the number of the labs in state, increase the capacity of the each lab, and third was ensure the supply of quality control reagents at an economical cost. There was no end visible. We didn't know where to go and how to go. All said and done, we had to take the steps for increasing the number of the labs in the country. For increasing the number of the labs, few things which have been done have been very beautifully elaborated by Professor Bhargav. What ICMR did for 100% of the population of country, KGMU as a nodal center for Uttar Pradesh did it for 20% population of the country. So our experience may be smaller, but it's almost similar. The one part was, first point was, we have to develop the infrastructure, which was for lab space, equipment, manpower. Every medical college has to be enrolled, may it be new or old, government or private. And a very master stroke, which was played by NMC, it made it mandatory for all medical colleges in the country to start a BSL-2 molecular testing laboratory. That was essential for them to continue with their recognition. Private sector labs were involved, and to maintain the quality, only NABL accredited labs were asked to participate. Research organizations were involved, those which are already familiar with molecular technology, medical, non-medical, botanical institutes, everybody who had some experience with molecular testing, veterinary institutions, all were involved. And all this required mentoring. KGMU played a pivotal role here. It served as a state nodal center for COVID testing. It was also ICMR nominated reference lab and the Mentor Institute. For mentoring, the KGMU worked on several fronts. One was the trainings. This was a very, very essential part. We did molecular testing training, biosafety, biomedical waste management. The staff in the field was trained for sample collection, packaging, transport. The private labs needed the training in NABL accreditation procedures that was provided. Every method of training was used. We used hands-on training in the laboratory. Videos were prepared and shared. Online trainings were provided. Even there was a need, if there was a need, on-site trainings were provided. Hand holdings and retrainings were also desired. We are still doing that. It has not stopped. Lab spaces need to be developed. It was not really possible to make the new laboratories. So whatever spaces were available, they were redesigned and developed. Equipment specifications were written and the procurement was ensured. Reagent specifications were written, procurement was ensured. And for quality testing, KGMC also played the reference center, which was very, very essential part. As a nodal center for EQUAS, we provided EQUAS to all the laboratories which are working in the UP. Initially, it was done monthly. Now ICMR wants it 3 monthly, but state of UP, I got a mandate from them. Yesterday only, we have to continue it once every month for the state of UP. If there's a need, we provide training and retraining and NABL accreditation. As a result, I'm proud to say that today 260 labs are working in UP, which is almost 10% of country's laboratories. Majority of them are in government sector, few are in private sector also, and we have many antigen detection labs which are also working. So there's an enormous, huge laboratory network which could be created as that. When we come to the steps which were taken for increasing the individual lab capacity. And the picture here shows the flow diagram of the pooling experiments which were done for pooling the sampling and testing for COVID diagnosis. So the points on which focus was there, one was infrastructure development. To increase the capacity of individual lab, new high efficiency equipments were added. Underutilized, maybe the space, machines, or manpower, they were deployed in COVID testing. Unskilled manpower, which could not be trained for the complicated jobs, were used for relatively simpler jobs like unpacking the samples and receiving the samples, etc. We had to economize on time, reagents, and manpower. So there was a game changer, and I'll call it pooling of the samples for testing. Make in India was a master stroke which was given by the government of India. Kit validation centers were developed across the country and ICMR supported them to a large scale. KGMU is one of them, and we have also validated many, many kits by now. Data management, lot of time was going for the managing data. ICMR portal, Professor Bhargav has shown. UP government has also developed a beautiful portal, merge it with the ICMR portal, and so laboratories now do not have to do any data entry except the results. Everything already comes to us. That was again a master stroke, and every possible technology was used for testing, maybe automated platforms, manual methods, and lot of technologies which have already been shown by Professor Bhargav. Currently, we are using RT-PCR, using our own brews and kits. We are using automated platforms like GeneXpert, TrueNat, Abbott, and alike. We are using antigen detection also wherever it can be employed, following the ICMR algorithms. Antibody detection tests are being used for serosurveillance only. This is one of the screenshots from UP COVID-19 management portal. Very, very beautifully developed system. We are so happy after that. And it is merged with the ICMR portal. So whatever we put on UP portal automatically is pushed to ICMR portal. So that saved us a lot of effort. As a result, our current laboratory capacity expanded. Till date, we have tested about 8.5 lakhs of tests, more than 8 lakhs for sure.
Capacity is around 6,000 tests per day. This is for KGMU only. Maximum samples we have tested in a day is 7,200. Total UP has tested more than 20 million tests, and our per day UP state's capacity is 1.75 lakh tests per day, which is highest in the country. Supply of affordable reagents of good quality was very essential. And this is one of the pictures from depot at KGMU. So this, again, the work was done on many fronts. One was establishing the depots across the country to maintain the demand supply gap. KGMU also served as one of the depot, and we have developed a beautiful structure out of that. Now, once the ICMR supplies are being shifted to state supplies, this depot is still working. Validation centers for the kits. Initially, we were using only FDA approved kits, but now, since the kits are being validated by ICMR approved system, KGMU is one of them. I've already said that. And Make in India was one of the best thing which could happen, gave us the highest quality reagents which are made in country. With that, I thank you very much. And since our story is complete from 72 to 7,200, this is a 100-time jump. And this was only possible because of all the help from everyone I got: KGMU administration, my magnificent team, ICMR, UP government, and the government of India. Thank you very much, everyone.
Thank you so much, Professor Jain. I would actually like to congratulate you for putting in such a great exercise and so much of investment of energy and effort in getting all the tests done and being the center who is doing the highest number of tests in India. Now, we know that KJMU is a tertiary care center offering not only COVID care but non COVID care also. And our next speaker, Professor Rishi Sethi, would be deliberating on the care of non COVID patients in COVID times, riding two horses at the same time. Dr. Sethi, as we all know him, is a professor of cardiology and Dean Innovation Intellectual Property at King George. Several coveted awards, including the Dr. Dhavendra Kumar Young Scientist Award. So over to you, Dr. Sethi.
Honorable Vice Chancellor, Lieutenant General Puri sir, eminent members of this highly esteemed panel of speakers and moderators, colleagues, ladies and gentlemen. My job today is to discuss with you all the care of a non-COVID patient in COVID times, and also to present before you the efforts of King George's Medical University in this regard. I feel that COVID-19 pandemic is the real, true sense global crisis that has hit mankind after World War II, in a sense that it has affected every individual living on this planet, either directly or indirectly. While it is true that this is a crisis that has resulted in immeasurable suffering to mankind, it is also true that it has shaken from complacency the political class, bureaucracy, healthcare systems, scientists, industry, all alike, and all of us have been forced to think of a better, more innovative, more adaptive way to survive and to flourish today and in times to come. We all know that COVID-19 has affected around 60 million people globally, worldwide as we speak today, and it has caused around 1.4 million deaths. And the data as of 15th of November 2020, it has affected in India around 9.2 million people and caused death of around 134,000 individuals. So there's no doubt that our house is on fire because of this novel coronavirus, and it is judicious and justified to use all our resources to contain this fire and to extinguish it if possible. But while our attention is focused on our house on fire, one must not lose a track or sight of the surroundings for the other dangers that may be lurking in the neighborhood for now, causing more destruction presently, and in times to come. And in this scenario, if you take a look at the global mortality trends in pre-COVID times, we realize that around 80% of all global deaths was being caused by non-communicable diseases in pre-COVID times. So when COVID hit the world, most of the developed world saw an increase in mortality in the month of March and April to the tune that the mortality rate increased around 50 to 100% in most of these developed countries, and that coincided with the peak of the COVID-19 crisis. So a hypothesis was being generated that probably this virus will become more lethal than any other disease known to mankind and had the potential to wipe out a vast majority of human population. But was that fear true? We have to look at the data, and we see that of around 150,000 deaths that happen in the world every day, around 50,000 of them, one third of them, are being contributed by the cardio-diabetic axis. Another around 26,000 deaths is being caused by malignancies, around 17,000 deaths is being caused by respiratory infections, and we can go on so on and so forth. HIV and suicide account for around 2,000 to 2,500 deaths per day of human all across the world. And when we compare all this data to the COVID-19 mortality, we see that at the peak of the crisis, COVID-19 was killing around 7,500 individuals per day globally. And on an average, COVID has killed around 4,700 individuals every day. If you take a look at our own country, COVID-19 variably, depending upon the region of the country that we live in, has been around 10th to 75th most common cause of death, even in the peak of COVID times. So the hard fact of COVID time is that though it cannot be, the severity of the disease and this pandemic cannot be undermined, it is also true that the mortality of cardiovascular diseases, diabetes, malignancies, and other non-communicable diseases still remain very high, and we cannot lose the attention of these diseases as we deal with the COVID-19 disease. Coming to the King George's Medical University, this university not only drains a large city of Lucknow, but we also drain a huge part of the entire state of Uttar Pradesh. We also drain parts of neighboring states of Bihar, Madhya Pradesh, and Uttarakhand. And every patient who was reporting to the emergency of King George's Medical University was being held either in the holding area or in the triage area, and microbiological testing was done in each of these individuals. And depending upon the COVID positivity or negativity, they were shifted to the COVID positive or the COVID negative departments, the infrastructure being developed under the same roof in King George's Medical University. Now, one may argue that what is so special about it, because this is the kind of practice that has been followed by most of the hospitals in the country. What is special is that while many of the large public and private sector hospitals turn themselves either into a dedicated COVID hospitals or a dedicated non-COVID hospitals, King George's Medical University was providing this care under the same time, under the same roof simultaneously to both classes of patients, and it was doing so in a very large volume. COVID-19 facilities, the COVID facilities in King George's Medical University was created out of the existing infrastructure, and we created around 500 beds for the care of COVID patients. And at the same point of time, around 4,000 beds were dedicated to the non-COVID facilities. So given that King George's Medical University is one of the largest hospitals in the state, in the entire country, and also in the Asia region, this was the largest volume of COVID and non-COVID care being provided to the best of our knowledge. Coming to the individual department's experience, speak for themselves. If you take an example of the Department of Obstetrics and Gynecology, it was providing care to ladies all across the time of, even to the peak of COVID crisis. They have seen around 12,000 patients in their outpatients and emergencies, admitted around 4,300 patients from a duration of April to October of 2020, performed around 2,800 deliveries and around 1,700 major or minor gynecological procedures. Department of General Surgery was a little late to start because this was a department that is that is being really flooded by the referrals of head injuries, traumas, acute abdomens from all across the state of Uttar Pradesh. During peak of lockdown, where there was containment in the movement of people, the department was a little slow in terms of picking up the non-COVID care. But in the last 2 to 3 months, the department of general 7,000 patients and performed around 700 minor procedure. Department of Transfusion Medicine reflects the balance between the different department, and its figures reflect the activity of the other surgical departments in the university also. We can see between April and October of 2020, a total of around 17,000 blood donations were done, and this department provided blood or blood components to around 40,000 people in the state, in both in the hospital as well as the entire state of Uttar Pradesh. My data for cardiology is a little more extensive because it's my parent department, but I would like to use this data to highlight the fact that even in the peak of crisis between April and June of 2020, we were admitting anywhere between 200 to 300 patients per month and doing around 150 to 200 procedures per month. While as we speak, in the month of November, we would have admitted around 900 patients and performed around 600 procedures, which range from angioplasties to pacemaker implantation to structural heart disease, balloon mitral valvotomy, transcatheter aortic valve. So that roughly amounts to 30 admissions per day and around 20 procedures per day. We can go on and on about various departments, but I would like to conclude for the sake of time by saying that leading from the front line, King George's Medical University has made every effort to provide care for non-COVID patients all through the duration of this pandemic. And while constantly changing scenario of care of COVID patients has occupied most of our attention, the Institute has kept its sight and of promise of treating the non-COVID patients as well. I thank you for your time and your attention.
Good. That was just slides were very nice.
Thank you, Dr. Rishi, for your wonderful presentation. And our last speaker for today is Professor D. Himanshu. He's a professor of internal medicine at King George's Medical University and an expert in the management of infectious diseases. So I would call upon him to proceed with his presentation on COVID to post-COVID continuum of care.
Yeah, thank you, ma'am, for the nice words, and thank you I thank Vice Chancellor, Lieutenant General Puri sir, for actually providing us with this platform to discuss different aspects of COVID. With this, I would like to present my presentation, which, as suggested, is COVID to post-COVID, the continuum of care. Now, that's like actually swimming through the last 8 months, where in March we had no idea about what we were really dealing with, and now in November, reaching December, we still think we still have a lot to know about this disease. I'll start off with a small scenario, which actually the truth with which I understood what COVID is. It started on March 11th. Before that, we were actually getting a lot of suspected cases, and we were testing them, and they were all negative. They were all the NRIs or the travelers returning from foreign destination. But on March 11th, we had a family of husband, wife, and a 2-year-old son who had come back from Canada, and NRIs. They had come back from Canada via United Kingdom, and at that time, UK was one of the 14 countries which had to be really tested for. They presented to us with fever. Both the husband and the son, they presented with fever, and the lady was totally asymptomatic. She initially did not think of testing her, but we took a detailed history. She just said she was having mild weakness or fatigue rather because of and she attributed to a jet lag. She herself was a doctor, and the hospital where she was working at, they had few COVID patients which were there. So just sort of a clinical acumen, we thought, we should go ahead and test. We never know, maybe she might start spiking fevers after a day or two. Let's go and have a look at her. So we did the test, and what happened is, first of all, we got we were reprimanded by the CM office because at that time the protocol was test if there were symptoms, because that was the protocol world over, that they did not expect at that time to have asymptomatic carriers or such people. The results were actually different. Both the husband and son were negative, and the wife was positive. And that was my first experience with COVID. That's where we understood that COVID can present in multiple ways and asymptomatic carriers can be present. And that came to light by March end. The data was there, enough data had started pouring in from world over that we can have asymptomatic carriers, asymptomatic people having COVID, whether they were truly asymptomatic or not, or would they have mild symptoms which were not totally, correlating with the natural what we expect, fever, cough, and all, or the sore throat. That was a different matter, but they were all by and large asymptomatic. Did they spread or not? That was the second thing which actually I understood because we kept on testing and this lady became negative by 12th day. But during this period, she had already infected, we started doing contact tracing. And once the contact tracing was put in place, we found that she had already infected 9 others. So that means the asymptomatic people could actually infect. That was the second experience which we understood immediately from the first case itself. No, but that my experience did not end there with this patient. That was after 2 weeks after she improved, she had a routine CBC test and all. She just got herself tested, and the automated counter readers they gave her a reading of 4,000 platelet counts. And she came back to us that why am I having 4,000 platelet counts? We redid it on the automated counter again. We kept on getting something like 4,000, 5,000. So we thought of looking at it, and we did a general blood picture. We wanted to do a manual platelet count, and the surprise, actually in real, she had 15 lakh platelets with large platelets. And that was my first experience with post-COVID, that you can have a lot of things which can occur after the COVID actually even disappears. And that was her slide. You can see the whole slide filled with platelets, with large platelet, clump platelets. Due to the sticky nature, the automated counter readers were actually picking it up as low counts. So this was the beginning with which we started off. The very first case taught us that COVID can present in multiple ways, and post-COVID, you can still have a lot of things which you need to remember about. Since then, it's been a long journey. The peak started in Lucknow around July. Our first severe COVID experience was around June, and we had our first expiries around June. But during this period, we had gone through a lot of patients. We saw lots of patients, and the world also. And the most common syndrome, which we all know, is fatigue. They are known to have a chronic fatigue syndrome like experience where the patients can have a marked fatigue for 2 to 3 months, persistent dry cough, persistent loss of smell and taste, lung fibrosis, one of the dreaded complications which can occur. And though we have been following up our patients till now, luckily, even at 3 months, most of them have actually shown that they did not develop fibrosis. But this is something which has been reported well from many places. Then we also saw patients who were actually non-diabetics whose sugars and all shot up. Initially, we thought it could be just because of the treatment pulse or the stress, but no, they did show an increase. And now we have data which shows that COVID, because of the ACE2 receptors, does involve even the pancreas and leads to a certain bit of derangement in the insulin levels, leading to increased sugars. We have seen deranged thyroid functions, maybe because of the viral thyroiditis, where we saw the patient's thyroid levels jumping and they automatically started improving after 2 to 3 months. Then, of course, the one thing which you have to remember, many of the times these patients used to come back with certain fevers. Many times people keep on testing for COVID. They did get initially, in some of them, positive COVID reports, but which we know could be just because of dead virus, which could be, again, caught by the PCR test that we do. Luckily, we went beyond that, and then we saw that there were a lot of dormant viruses like herpes, like CMV, like EBV, which were actually getting activated. But we could detect them by PCRs, and once we treated them accordingly, specifically herpes, which we have treatment, and CMV, the patient started showing improvement. So that itself something which one has to remember, because as such, the COVID is known to suppress the immunity, and moreover, in the treatment, we're using steroids, which sometimes can lead to the reactivation of the other dormant viruses. Kawasaki-like syndrome is well known, specifically in the pediatric age group, which has been shown to be seen. Fortunately, we did not come across any such case, though we have been the main pediatric center for the whole area of Lucknow, and we have been seeing lots of pediatric COVID patients. But luckily for us, till now, we did not have any such feature actually developing in our patients. So I'll go ahead beyond what these post-COVID symptoms, which are or syndromes which we have explained here, and I'll give you some bit more of my experience. In the August, my learning curve again took a new turn when a 57-year-old male, he who was diabetic, morbidly obese, was admitted with us with severe COVID. I still remember he was on HFNO machines with a very high flow rate, so and was there for 14 days on them. And we just then the remdesivir had started coming. We were not sure what to do. We were using basically steroids, and of course the other antivirals, which now most of them have been left behind, which do not appear to be of great use now. Uh, so basically, the patient was treated with oxygen on HFNOs and steroids, and he took nearly 20 to 25 days, and he improved, and then he was discharged on room air after he became asymptomatic, and the COVID samples were also negative. But after a week after he went home, he again started complaining of new onset fever. He started spiking fever. He was readmitted. Cultures, blood cultures, urine cultures, and inflammatory markers were done, just suspecting maybe the patient might have developed some secondary bacterial infections. But what came back was something surprising, a ferritin level of 60,000. A ferritin level of 60,000 is a very direct suspicion of hemophagocytic lymphohistiocytosis syndrome, which had been actually suspected even in few cases in few patients in a series from Italy. And now we have data even from US, and we have also our own data which shows that there is enough hemophagocytic which is seen in COVID patients. But at that time, we went for bone marrow examinations, we gave him high dose steroids, and this is what turned up. So you could see the histiocytes and macrophages actually eating up the different cell lines, specifically the erythrocytic and the other normoblasts and all. And we also did CD68 staining in these patients and in these slides, and we found that there were increased number of histiocytes with engulfed nuclei. So till date, we have seen 17 HLH patients have been diagnosed, most of them in post-COVID who were not improving, or post-COVID patients who actually again reverted back and had to be readmitted. And HLH is a serious complication and needs emergency treatment. And once we started treating them with high dose steroids or with other immunosuppressants, and we started actually seeing recovery in these patients. We have also actually diagnosed HLH even in the COVID patients itself, because we started doing bone marrow biopsies and bone marrow aspirations much more commonly even in the active COVID patients. And we have now a list of patients of COVID also who are having actually HLH. By September, we again saw something different. A 27-year-old male with a history of fever, sore throat, presented with marked weakness of all four limbs and difficulty in breathing. He was having actually sinus tachycardia, areflexia. So we suspected, Guillain-Barré syndrome, and we did an NCV study, and we found that there was axonal demyelination. He was treated with immunoglobulins, IV immunoglobulins, and there was a complete improvement in his syndrome. So this is something else which has been seen internationally, that you can have Guillain-Barré syndrome and maybe the auto antibodies which are being produced, leading to the injury of the neurons, the demyelination, and which can lead to Guillain-Barré syndrome. We have now series in our own setup, and I think there's been some series from from Delhi and Mumbai also recently, which have been seen. So, but we have had 5 patients in the last 2 months. 2 of them were associated with pneumonitis, but the interesting fact is we were able to even isolate COVID in CSF. As a matter, we also did not believe it. So we did repeat it. We took the same sample. We had to repeat 2 or 3 times whether it was some contamination or something. But no, we found COVID in that, and that is very interesting, because there are few cases where they have done then and seen this COVID in CSF also. And this becomes very important in the scenario that nowadays we also know that there are different neuropsychiatric symptoms and presentations in COVID, and which is now being called as a COVID encephalopathy, which could be directly because of the COVID virus. The teaching curve in COVID and post-COVID did not end there. Even recently, to the end of November, we had a 26-year-old male presented with pneumonia with altered behavior, and was found COVID positive. Was evaluated for the acute encephalitic syndrome, the list of viruses, the bacteria, and the parasites that we always check for, but no other causes were identified. The patient was put on a ventilator due to severe COVID pneumonitis. He improved, in fact, a tracheostomy was done, and he was removed from the ventilator. His COVID became negative on 3rd of October, but he continued to spike fever intermittently. And then he was readmitted because of his fever and was retested. His platelets, hemoglobin started falling, and his ferritin was 933 nanogram per ml. So, as we thought, with our experience of the past, from our August experience, this case would be most likely another case of HLH. We did bone marrow and GBP as a routine, and we went about doing all the other tests as a routine for this patient too. What turned up was something totally different, and this is a patient who's still with me, and the patient had huge number of fragmented red cells lying about it, seen about in his slides, and this was a case of thrombotic thrombocytopenic purpura, and he's been kept on that, which is another new, and there are very few cases which have been reported internationally, and which is suggestive that COVID can lead to an immune reaction, which can lead to presentation in different manners, specifically in the post-COVID scenario. If you're getting these patients even after the COVID becomes negative, then one has to keep a very open mind and keep looking at different aspects of the immune reaction to actually treat them. Now, the patient was initially given IVIGs and then a bit of we did plasma exchange. The patient is stable. The ADAMT is 13. The values we wanted to check on that. We have been still waiting for that. But now he's started improving. That is something which actually shows that if you are able to identify these immune reactions, you can actually provide better care for these patients. So, what's our experience in King George Medical College? For the last 8 months, we have had more than 3,500 COVID patients with 283 post-COVID patients, serious patients who have been admitted, and 93 who have finished even 3 months of follow-up with even HRCT thorax. Luckily for us, most of them have reverted back. We did not see any fibrosis, and they have been maintaining. And what I can say is that even now, we are still learning. The learning curve does not stop. It keeps on going on. And that's what I wanted to present to here, that the COVID to post-COVID has been a huge learning curve, which goes on and on and on. And I think there are a lot of things still we need to understand. Before I finish, I would just like to say that in this scenario where we wanted to learn more about COVID, the King George Medical University has been actually playing an active role in providing for the different scientific contributions. Some of those studies which you heard even with from Professor Bhaga, where he suggested that the different important studies. For example, we have been a member of the PLACID trial, the plasma therapy trial, the antibody trials. We have been also been a state center for the national registry, which has been started, where we would be compiling up all the clinical profiles which we can be most probably seeing in COVID. We have been part of the BCG vaccine trials, even the Ayush Ministry trials for COVID treatment, for prophylaxis, the newer drug repurposing trials with multiple agencies for omefinavir, and we have been also trying to do diagnostics with using artificial intelligence for COVID-19 using chest X-ray. So these are few of the trials, but KGMU has always been trying to contribute its own part in the scientific knowledge which might be helpful in treating this disease. Thank you.
Thank you so much, Dr. Himanshu, for this very interesting presentation of yours. In fact, COVID-19 infection can certainly have very aberrant presentations and post-infection sequelae too. And all we can do is to keep our eyes and ears and minds open for them. So with this, we come to the end of the seminar and the webinar. And now I would request our Honorable Vice Chancellor, Lieutenant General Bipin Puri, sir, to give his closing remarks.
Thank you all. I think many of our star speakers have left the webinar because of some their commitments. But let me summarize and say that how thankful we are to all our guest speakers, all luminaries, all doyens in their own particular field. And I thank each one of you profusely for contributing to these academic deliberations. And I have to name them. First is Additional Chief Secretary, Dr. Rajneesh Dubey, Professor Naresh Trehan, Professor Balram Bhargav, Dr. Das from ICMR, Lieutenant General P.P. Verma, and of course, the in-house, our in-house consultants who have done a remarkable job, and Amita for comparing the show and holding everybody together. So once again, thank you very much for putting up the whole show together. And thank you once again to all and for this wonderful academic feast that we had on this Saturday morning. Thank you so much.
Wow,